Hi everyone.
Hello.
Hi. How is your weekend going so far?
Excellent. Just started.
Yeah.
How are you, friend?
Huh?
How are you?
Yeah, I'm good. I'm good.
You must be tired.
Yeah, I mean, a little agree with that. I don't know how I'll be able to pull up this over the weekdays. Right now
Yeah.
it's weekend.
Now, do we have any schedule put up? Like what are the days when you will have the sessions?
Yeah. So actually it's gonna be every day. Let me show you the schedule quickly. So the schedule I should have shown you yesterday itself. So in the WhatsApp group, you see this is the HemePath WhatsApp USA group.
Yeah.
And you can see the flow course materials, right? So go into
Yeah.
that flow course materials and you will see the schedules and materials. So go to the
I
schedule.
See.
And
Yeah.
that's the schedule for United States.
Yeah.
So basically we are going to have more like today is 31st and we are going to have the introduction of flow cytometry and so forth.
Yeah.
The second part and third part. And then tomorrow is again Sunday, so we can have bigger session of larger B cell populations.
Okay.
And then so forth, like all the session is over here. We are going to try to stick to this, but there will be deviations to that, of course,
I
based on
see.
availability and everything.
Wow. I think this is wonderful. You to create in a nice schedule, and the only thing is just people have to know that it is sitting there in the schedule thing.
Yeah, and then another thing that I have over here, if you go into the same flow cytometry course, I'm putting the materials in. Let me mute.
I see. I see.
So there are these course materials, and the course materials, you can see the general course materials that have a lot of things, and then also the Brentwood book and so forth that we'll be discussing. And then we have the daily course material. So we had the day one materials. So this is what we discussed yesterday. The flow cytometry setup that Raji discussed, and flow slides intro and Brentwood article that I was discussing basically. And the day two materials, this all things we won't be able to cover, but let's see how much we are able to cover in the day two.
I see. Very nice. Good luck.
Thank you. So let me go to the downloads, day two materials. All right. So today we are going to go more into how the myeloid gating, B cell gating and T cell gating was done at MSK. I mean, we used to get already gated plots. We were kind of spoiled. So I am also going to learn with you. Apart from teaching you, I'm also going to learn with you. And another thing is the gating that usually the other formats have, like for example Kaluza that we use right now, and other things that that Raji has a different one as well. So the other things, the gating will be different, and I'll try to show the Kaluza as well because the gating is different. But this gating will help you overall throughout your career whenever you are doing the cytometry. So let me go into the myeloid gating. Okay, so these are the SOPs, the flow SOPs from Sloan Kettering, and this is what I'm going to discuss right now. Okay, so starting with the erythroid cells, this is number 2.
Yeah.
Actually, let's use the Google Drive file. It's much easier. Okay. So this is the same file that you have in your that you have in your system, and I have made this file viewable but not downloadable for obvious reasons. So you cannot download all these SOPs, unfortunately, and they will be available for the time that the course will be here. So I would see if I can make you available. I mean, it will be available for the recordings too. All right. So now we know the erythroid cells, they are CD71 positive and they are CD45 dim. So this is one thing. When you start gating your erythroid cells, you go into the CD71 positive cells that are CD45 dim. And again, yeah, going back to what we learned yesterday, these are the granulocytes. So the green population is the granulocytes. The blue population is lymphocytes, and then the pink population is the monocyte. So basically it is reversed. If you remember, the 45 was over here last time and you had a little different plot. But then the red population, I'm telling you all the population colors here, the red population is going to be the blasts. So these are the erythroid cells, which are 71 positive, and that's how you're going to gate them. The other thing is that the erythroid is displayed on CD15 versus 71 to include bright CD71. So again, bright CD71. Remember that there could be some, you don't have to gate it the whole way. That is, do not take the 15 into account, because the 15 will have the granulocytes. So as I told yesterday, 15, 16 more mature granulocyte markers, right? So exclude those granulocytes in your gating. Next is again CD34. So CD30, so again, exclude the CD34 because the CD34 positive will be the blasts. And if you have maybe the erythroid blasts, you can see that they will be over here maybe. Usually erythroids are 34 negative anyways. So you can see the erythroids, they will be 34 negative and CD71 positive. Next, coming to, so over here, B cells and plasma cells. So B cells, obviously we know that 19 is the B cell lineage marker. So it's a lineage defining marker, and you gate on, so basically as we were talking that the side scatter will be higher on the granulocytes, and then the blasts will be having dim side scatter. Lymphocytes will be having lowest side scatter because it will be having no granularity, right? And monocytes will fall in between the granulocytes and monocytes, as we spoke earlier. So over here, B lymphocytes will be more of CD19 positive and dim side scatter cells. And they're also showing that similar CD19 can also be present in the plasma cells. So normal plasma cells, if you remember, your normal plasma cells will have CD19, but when they become abnormal, as in case of myeloma, they lose CD19. So that's something that you have to remember. So CD19 will be positive in the normal plasma cells, and they will be having higher site scatter than your normal B cells. Now coming to 34 versus 19, so there is this spectrum. There's this spectrum, and you can see, you can see that 19 positive and 34 negative. These are your mature B cells, right? So they are 34 negative and 19 positive. 34 positive and 19 negative. So basically 19 negative, that makes them more of myeloid, and 34 positive, that makes them blasts. So 34 is your stem cell marker. So that those are the myeloid blasts. And in the intermediate, these are the immature B cells. So basically the immature B cells that will be having some 34 over here, like they will be still having 34, they will be having dim 19. So those will be your immature B cells. Mast cells. So mast cells, they express CD117. So this if you go over here, these are the WBC, the normal myeloid blasts, right? So these are the red population is the normal myeloid blasts, and above that, the brightest. So the normal myeloid blasts are also CD117 positive, and if you compare them to the other populations, it is kind of the brightest CD117 because they are myeloid blasts. So we also, if you remember our Brentwood gate chart yesterday, I showed you that CD117, 34, all of these are present in the myeloid blasts. Now the mast cells, they are brightest CD117. So that's what you will get. The bright, you can see, I mean, I don't know if you see those small tiny dots in here, but those tiny dots are the mast cells. So over here, you can see this picture on the right-hand side. So again, this the red population is the blasts again, but however, you see a lot of mast cells in this one. So you see that if you see this kind of a lot of mast cells in this gate, you have to gate it separately for seeing that if it is having any mastocytosis features. A mastocytosis SOP, I'll go with it when we are doing the mastocytosis. But this is kind of a lot of mast cells which we should remember to gate and analyze further if at all present. Coming to myelomonocytic. So myelomonocytic, let's go to the Brentwood article again. That will be easier. So because we have already read this Brentwood article yesterday. This is B cell. Let's see. Granulocytic. So I'm going to go a little bit to granulocytic and monocytic again in order to understand what I am showing there. We remember that granulocytic, more mature ones will have CD15, that is bright. As I showed in the earlier WHO chart, that the granulocytic will have, the monocytic will have higher HLA-DR. Let's go over. So here we were. So see, the HLA-DR is brighter in case of monocytes. So this pink population is the monocytes, this red population is the blasts again, and this green population is the granulocytes. So you can see I was talking about CD33, and over here CD33 is a little bit brighter in case of monocytes. However, how you differentiate, because HLA-DR is much high, increased in or brighter in case of monocytes. On contrary, CD33 has kind of a spectrum in case of normal granulocytes, and it will be kind of bright to dim, bright to like not dim but intermediate. And however, it will not be as bright as the monocytes. So, and then these are your normal blasts. So as I mentioned, that the normal blasts will be having HLA-DR, and they will be having 13, 33, and so forth. So that's that. So again, the monocyte gate, so as I was telling, side scatter, right? So side scatter, as we have been talking again and again, that the highest side scatter would be for the granulocytes, middle will be monocytes, and the BRAST will be having the low side scatter. So in CD45 versus side scatter gate, you would see that the monocytes, if you remember, the lymphocytes will be on the top of CD45, the highest CD45, and in between the CD45, the lymphocytes and the granulocytes will be monocytes. So once you have gated that, you have to exclude the granulocytes and blasts by doing this, and that's, I mean, this all is more of what is done by our technicians, but this is something that will help you all the way. Again, so as I was saying, CD15 is more of a mature granulocyte marker, right? So CD15 and then CD33, another one. So CD15 and CD30, the bright CD15, we know that these are not monocytes, these are more of granulocytes. And then you see over here this blue population, you know that this is CD33 negative, CD15 negative. It's more of, can someone tell what kind of population is that? Anyone?
Lymphocyte.
Lymphocyte. Exactly. So this is not having the myeloid markers. This is more of a lymphocyte population. Very good. Now coming to plasma cells. Plasma cells, they have brightest CD38. So as we were talking about the CD38 in the grans, we were saying that CD38 is kind of variable in the grans. We read that yesterday. The plasma cells will be gated based on the brightest CD38. Okay, so that's that. Okay, so they are saying over here that gate on 64 bright and 45 bright to get the entire. So basically they are gating on this entire population, and also they are gating on the dim CD64 and bright CD45. So basically this myelomonocetic, they are also gating on both of the populations that are dim 64 and bright 64. If you remember our Brentwood article, that's what we were talking about, that 64 has kind of a maturation pattern, and it is in the more mature monocytes, it will be more of brighter as compared to the immature monocytes. So again, emphasizing the same point that HLA-DR will be brighter in case of monocytes as compared to the granulocytes. And as I was saying, 15 and 16, if you would remember, as mature granulocyte markers. 15, though it will be present in throughout the series, but still it will be brighter in case of mature. Similarly, 16, so it will be more of a spectrum for 16, but it will be brighter in case of mature granulocytes. So they are saying that in the monocyte gate or this gate, just exclude the brighter granulocytes that you don't want. So coming to the mature and immature that we were talking again, CD14. So someone asked yesterday, CD14 can be used for gating immature monocytes, right? So over here, you can see the brightest CD14 will be more of mature monocytes. And when it goes over here with, and then we were talking about this kind of signs that yesterday, that the monocytes, they have this kind of, they dip in the promyelocyte stage for HLA-DR, and then they kind of increase again when they are going into the more immature monocytes. So basically, pro-monocyte, not promyelocyte, pro-monocytes. So basically, that's how your HLA-DR looks like in case of mature and immature monocytes. So basically, the CD14 will be brightest and highest, along with HLA-DR that is brightest in case of mature monocytes. Then it kind of dips for the HLA-DR, and also CD14, it kind of dips, and the dim CD14 and still bright HLA-DR, that's what it will be for mature monocytes. Also, granulocytes, as I was saying, to remember that granulocytes will be dim CD14. So yesterday I was telling about that. To differentiate between the monocytes, mature monocytes especially, the granulocytes will be CD14 negative. As I have been emphasizing, that HLA-DR will be brighter in case of monocytes as compared to the granulocytes. So again, CD64 will be there in the monocyte gate. So again, that's one of the monocyte markers. But if you see over here, the CD64 is also present in the granulocytes. The only difference between those two are that the site scatter is higher in the granulocytes, and the site scatter is lower in the CD64 in the monocytes. Okay, so let me try to. So again, this blue population, for now we have understood that the blue populations in our flow plots are lymphocytes. So lymphoid population. So basically, CD13 negative, CD64 negative, these are your lymphoid rough gate. Okay, so let me mute, someone is there. Okay, so this is your site scatter versus CD34, and we already saw that from the DIM45 gate, we gated on the CD34 positive blasts. This CD34 positive blasts will also be the ones that will have hematogones and immature B cells or early B cells. Coming to the basophils, so Shweta was talking about everything, gating about basophils and everything. So this is how the basophil gating would be. And so basically HLA-DR and CD123. This is going to differentiate between the plasmacytoid dendritic cells and the basophils. The plasmacytoid dendritic cells and basophils, both of them will have CD123. So you have to kind of mug up. The CD123 is positive in plasmacytoid dendritic cells and basophils. However, the HLA-DR positive, like bright HLA-DR, will be there in plasmacytoid dendritic cells, and the dimmer HLA-DR will be on the basophils. So, but again, both of them are bright CD123. And coming to the same point, as we have been emphasizing, the pink population over here is brighter for HLA-DR. That's our monocytes. And this population with the dip and everything, this is our granulocytes. So they are showing over here the eosinophilic rough gate. Till now, we have been talking about the granulocytes, blasts, lymphocytes, monocytes that will lie somewhere here. But this that have highest site scatter, if you may, like eosinophils, they have the highest site scatter, and they are brighter than the granulocytes for CD45. That's your eosinophilic rough gate. And then another thing would be that eosinophils, so again, CD16 is more of a mature granulocytic marker, right? So CD16 negative, but CD45 there is your eosinophilic rough gate. So this is more of your mature, the peripheral blood so far, any questions like, does this make things clearer as to how things will look like in a normal one? Any questions? Jayashri, Rajeshwari, do you have anything to add? Are you here?
Yeah, I'm here. I just wanted to say that plasmacytoid dendritic cells and basophils, they will sit along with the blast in the blast gate, which is why like we have to differentiate them using 123 and HLA-DR, because in CD45 versus site scatter, they sit together and in the blast gate, and we have to be sure that we don't call them as blasts. So we need to make sure we exclude them when we gate for our blasts.
Right.
That's one thing.
Okay. Thank you. All right. So this is your normal peripheral blood sample blast, they're saying. So, I mean, this will be, I mean, let me skip this and go into myelomonocytic. I mean, actually, let's not skip. So this, they are saying that the normal blasts versus abnormal blasts. Anyways, the peripheral blood are not supposed to have blasts. So this is a population that has blasts in the peripheral blood. But however, the blasts, they will be having CD34, 13, 33. So these are your normal myeloid blasts that should not be spilled over in the peripheral blood. They are still in the peripheral blood, but they should be less than 1% anyways. Myelomonocytic, so what we have been emphasizing, this is all together, what we read till now. And let's see if we are able to make sense of this. So this is your normal peripheral blood myelomonocytic plots. And what we have been reading is CD15 bright, and then 33 dimmer than the monocytes. So it is brighter in the monocytes and dimmer in the granulocytes. So this granulocyte population and the monocyte population, again, the lymphocyte population will have negative. This 34, there will be, if at all present, there will be some cells over here which will be less than 1% in the peripheral blood. And again, CD15 bright, middle, and none for here. CD38, yeah, go ahead.
Okay. In the first plot, what is that black population beneath the pink population? Just out of curiosity, I wasn't able to figure out. Between that blue and pink, there is some black population underneath. What is
Yeah.
that?
Let's think about it. I think they have not just gated this black population, they have just left that black population. They might be the normal blasts as well, because you see they have increased CD33 and they are dim for CD15.
It looks like they have CD38 also.
Yeah, so it looks like
could be your EOS. Could be EOS, but EOS would have CD50. So no, not EOS. Sorry. Yeah, I don't see anywhere else.
Let's see what they are doing. I mean, if we could have gated this and seen where exactly everything is lying, then it would have been easier. But since we cannot gate this right now, it's a PDF. So
Is the RBC debris?
the RBC debris will not have CD33.
Okay.
They could be basophils over here, because as we know, the basophils can also lie in this place.
And
Yeah,
basophils can have 38 also. So
Yeah,
that's what I was thinking too. Yeah, maybe.
Yeah.
Okay.
Okay, good. So again, so CD38 will be negative in case of granulocytes. We have been seeing that. 13 bright. So 13, as we are seeing, and HLA-DR. So we saw this already, that brighter HLA-DR and monocytes, but these both of them will have CD13. CD117. So CD117 is an immature marker, and it will be negative in both mature monocytes and mature granulocytes. It's more of a mature myeloid marker for that matter. This is all the repetition. CD64. So CD64, as I have been mentioning, that there was a mention that CD64 will be there in both myeloid and monocytes, but I want to emphasize that CD64 will be brighter in case of monocytes, and then it will be dimmer, though it might be some partial positivity, but it may be dimmer in case of the granulocytes. Again, CD16 grans, CD16 is negative monos, and then again CD64 positive monos, CD64 negative grans. So this, once you see it step by step, things start getting easier and understandable as to how they are going to be. For example, CD64 and 14 bright, these are your mature monocytes. Okay. So we already saw all of that. Bone marrow normal blasts. So, you know, you have to differentiate between the normal and abnormal bone marrow blasts. Why? Even if they are less than 5%, we say that they are the normal bone marrow blast should be less than 5%. But in case of MDS, myelodysplastic syndrome, even those, the normal myeloid blast and all those population will have aberrant markers. So in MSK, they used to, place importance on what a normal blast will have a maturation and like how it will look versus an abnormal blast and what are the features, and we are going to see that. Meanwhile, in the myelomonocetic, do you have Rajeshwari is having some problem entering into the room. Rajeshwari? Hi, Rajeshwari. She's getting out and coming in. Okay, anyways. So, so far, do you have any questions of myelomonocytic that we discussed? Is it clearer in your minds as to how it will be?
It is really good. Like, it's really falling in place in my mind right now. Just one thing, when you decide upon which markers should be on Y and X, is it a pattern that each lab has to decide, like what they will gate against, or is it like a common, kind of a protocol that you follow?
No. It is not every lab develops. I'm sorry, I'm getting the echo. Every lab develops flow in their own fashion, and they develop their own plots. And even when you have like Kaluza or something else, it's not like they will be all standardized. It will be every lab develops their own panels, and not every lab have all the panels. Not every lab like this. What I am showing is from MSK, right? So they are more elaborate. And actually, if you go and see, let me show you the normal Kaluza. So, for example, this is the normal peripheral blood flow, and if I can. The normal Kaluza, it will not have so many plots. So you see they have plots over here, and there are more of that. But they will look different. For example, let me go back here. For example, again, so this, so this is more of what many labs will have. Like this is different than wood list. Again, so I am showing that wood list to clear the concept because it is very well mentioned in there. But the normal lab will have more of this kind of scenario. And however, the basic concepts will be similar, what we are talking about. And then there are more of normal plots in peripheral blood, but maybe if we get time today, we can go through that. Yeah, to answer your question, it will not be the same in case of
sure. Thanks.
Yeah. Anyone else has any questions?
So most people just use CD45 versus side scatter to
Yeah, that's right. They use CD45 versus side scatter for the first one. And they actually use CD45. So what I was showing over here, they actually use CD45 in the x-axis versus side scatter in the y-axis. So I don't have the CD45 here. Maybe I don't know. So, but what they use is CD45 in the x-axis and side scatter on the y-axis. That's the most of the labs that they use. Okay.
And those populations can actually be gated there, and they use the markers just to clean up, to just make sure that the CD45 versus side scatter gate is perfect. But mainly they use only CD45 versus side scatter first.
Right, exactly. Okay. Okay, so let's see how the normal bone marrow blasts are going to look like. I'm seeing this after long time. I mean, this has evaporated from my mind, but let's see together. CD117, as we know, they are normal myeloid blasts that are CD117 positive. The normal myeloid blast will have a spectrum of CD13. So you can see over here, the CD13 is kind of variable in the normal blast. If it is sitting very bright or something and only one population that is very bright, then you have to start thinking that it is abnormal. So you can see over here as well, the CD13 is kind of having a variable expression. HLA-DR also a variable expression. So everything that we learned yesterday, I mean, it must have evaporated in most of your minds, but unless you did a thorough reading again. But again, the spectrum of HLA-DR would be similar, like the blast will have a spectrum, right? Then coming to CD15, so blasts will not have CD15 as compared to the granulocytes. And CD34, as we know, it's a stem cell marker. That's how we know that those are blasts. However, it is so there are some blasts that are CD34 negative. Those are the abnormal blasts. Those are not normal myeloid blasts. So you have to remember that. They have gated the basophils over here as CD38 positive. So you have to remember that not only the plasma cells will be brighter CD38 as compared to even basophils. So but the basophils will also have CD38 and they will be dim HLA-DR. And then you can go ahead and do the CD123 and so forth. So yeah, CD33 as well, as we were talking about 13, it is kind of variable. So in the normal blasts, we'll be having a variable CD13 and then that CD117. All right, that's fine. So that's about it. Like, let's go to how they have shown a abnormal blast population, but let's go sequentially. But this we have this is similar to what we have been reading about myelomonocytes, and I don't want to repeat it again and again. But brighter HLA-DR, monocytes, dimmer CD15, a little bit brighter 38. Let's see, 13, which is similar to myeloid and monocytes. Myeloid and monocytes, yeah. So we have been going through again and again this. This is just that it is more of a bone marrow. So what we went previously was the peripheral blood. So the bone marrow will have more of more cells, of course.
Hi, Akash. This is Nithi. Hi. Hello, can you hear me?
Yes.
I have a question. I didn't attend yesterday. I'm not sure if you discussed this. Can you talk about a little bit about like 14 and 64 as monocytes mature? Like,
yes.
How do they
So
change?
actually, that was right. So that was actually discussed in very nicely in the Brentwood article. You can see, let me go to the myeloid. But again, this is so evaporating that even those who must have read this will be not remembering very well. So 14 is more of monocyte marker. So let me show you the monocyte plot. So 14 is more of mature monocyte marker. It will not be present in the monoblasts, and it will start increasing eventually in the promonocytes, and it will be brighter in the monocytes. At the same time, the myeloids, they will have very faint 14. However, they will be still dimmer than monocytes for 14. There will be much dimmer for monocytes. And only the mature granulocytes will be expressing a little bit of 14. And you were talking about 64. So 64, also as it matures, it will not be present in the blasts, and as it matures, it will be present in the promonocyte and monocyte phase. A little bit brighter in the promonocyte phase as compared to the monocyte phase. And as compared to that, CD64, again, it will be brighter in case of promyelocytes. So as you see, first it is absent in the blasts, and then it increases in the promyelocyte or myelocyte stages, and then it again dips down in the more mature forms. So that you will see in our myelomonocytic gates as well. Show that. Yeah, it's not. So this is the normal myelomonocytic in the bone marrow. So you see over here 64 that we were talking about. So 64 is brighter in case of the normal mature monocytes. This is a normal bone marrow plot. So basically it is not really showing a lot of immature monocytes because that's not normal in a normal bone marrow. But these are the normal mature that will have 64 brighter as compared to the granulocytes. And again, because this is not a plot that is showing, I can show you the plot that is showing the maturation of. So this is a plot that is showing the maturation of granulocytes, and the 16 and 14 and 64 will be more on the mature monocytes. So let me show you how it is going to be. So this population is the monoblast population, and when it matures, it will be maturing to more monocyte population. So it will be gaining the 64 as it goes from blast to monocytes. And as coming to the 14 that we were talking about, so the blasts will be negative for 14 as we saw, and it will be going as a spectrum towards the brightest in case of monocytes. So I mean, that's something that you can apply here as well. But at the same time, the spectrum of 14 is going to be much lower in case of granulocytes. And despite that, there will be a spectrum of 14 if there are immature. This is not much of immature here, but if there are immature, there will be a spectrum of 14, and but they will be still very bright as compared to the grans or myeloids. Does that clear something in your mind?
Yeah, no, that was super helpful. Thank you.
So yeah, I'm not going to repeat all of this. We already saw all of this and we have enough repetition. Okay, this over here is showing that obviously the blasts will be negative for 3, 4, 2, the normal myeloid blasts. So they are not the T cell blasts, that they will be positive for them. Okay, so now they are diving into the normal versus abnormal blasts. So as I was saying, that we have to differentiate between the normal blasts and the abnormal blasts. So the normal blasts, they showed over here that they will be having less. Let me go back. That they will be having not really much of CD4. So this red population, they will not be having much of CD4, CD3, CD2. They will be CD56 negative. CD5 might be like, it's not completely negative, but it might be a little bit over there, but still negative. And then let's see, and CD25 negative as well. So now they are explaining the abnormal blasts. So the normal blast, as we said, partial CD5. So as I was saying, that there is a little bit of CD5, but it's partial CD5 and CD2 expression. as you can see over here, partial CD2 expression. So wait a second, this, yeah, so this partial expression. So basically when we were talking about the normal blasts, they were negative for CD67, CD5 and CD2. So when you start getting the expression of T cell markers, those are aberrant in case of normal myeloid blasts. So they will be abnormal. Again, so CD19 expression. So normally the normal myeloid blasts, they are not supposed to have 19. That's kind of understood, right? 19 is more of B cell marker. It's a B cell lineage specific marker. But when it starts expressing CD19, then you start thinking that there is something abnormal. Do you have an example that it starts expressing CD19?
821.
Very good. Yes. 821, it starts expressing CD19. So those are abnormal blasts. Next, coming to CD117. So CD117. So you can see the brightest CD117 that is over here, and the CD34 that is absent. So this normal blasts will be having a bright CD34. These are normal myeloid blasts. So then when the myeloid blasts start losing CD34, then you, or else the losing CD117, even like this is a little dimmer CD117. So when they start losing 34117, those are abnormal blasts. Can you give me an example of negative CD34 that are in the myeloids, not in the monocytes and others, that are in the myeloids?
APML?
Yes, that's correct.
Hey, in the previous plot, first one, 3419 positive, do you don't need to exclude hematocones before calling it abnormal blast over there?
Yes, that's a good question. You would have to exclude hematocones. There will be other ways, but they are right now talking of the myeloid blasts, and they will be detecting the myeloid blast based on the other markers as well, like 1333 and others. So, but yes, you have to exclude the hematocones there as well. Okay, यहाँ तक ये कर लिया ना? Yeah. So, okay. So again, normal and abnormal. As I was saying, normal myeloid blasts will have a variable CD13, right? You can see over here, they have variable CD13. When a blob starts sitting, kind of a bright, uniform CD13, you start thinking that they are abnormal, right? Similarly, CD33, you see that they are having a spectrum, a variable CD33 expression. When it starts, a blob starts sitting right at a bright uniform CD33, you start thinking that they are abnormal. The same thing they are explaining over here, that uniform abnormal uniform CD13 expression, and also like loss of CD117. So this definitely is a very abnormal population. And this, you can see a normal blast will have the spectrum of CD13 and will have a CD117, which will be there. And we also remember the dip and everything that happens in the maturation. So you can see a normal myeloid blast with maturation will have this spectrum. As we are talking about the variable CD33, there is also variable HLA-DR. That is a spectrum of a normal myeloid blast that will be present. When you have again abnormal, as we were talking, that it will be sitting as bright CD33. Again, if there is a decreased CD33, a blob is sitting at a decreased CD33, that is also abnormal. A blob that is, so if it is variable, it is good. All that things that are variable in the blasts are good. If it is sitting at a place which is dim HLA-DR, you are starting to think that that's an abnormal population. Okay, so the normal myeloid blasts, they will be not having CD123. They will be negative for CD123. When they start having CD123, also they are showing over here the CD34 is absent. Those are your normal, abnormal myeloid blasts. The normal myeloid blasts will not have CD11B. CD11B, as we were talking, they will be seen in myeloid monocytic markers, and I emphasize that it is brighter in monocytes. But when you start expressing CD11B, those are the things that make them abnormal. And this is important because now we are talking about the normal myelomonocytic and abnormal myelomonocytic maturation. And this is important. Why? Again, if you go into the MDS charts, like there's a nice MDS overview as to how the markers, they are different or aberrant in case of MDS when they are like, to call it MDS, I wish that I would find it. I would have found it beforehand. But in case of MDS, there are certain things that are brighter. There are certain things that are dimmer, and they have abnormal set of things that there is a very nice chart that is available in one of the papers. But this is important. So why is this important? Because you need to differentiate between a normal myelomonocytic maturation versus an abnormal myelomonocytic maturation, or basically as that. So as we have seen over here, the granulocytes 16, as I have been emphasizing again and again, more of mature grants marker. So 13 variable, right? So 13 variable, 16 variable, as they mature, they start gaining more of them. And 16 kind of negative or dim in case of monocytes. So this is more of normal myelomonocytic. When you have, so basically when you have a 13 bright, that is 16 negative. So basically discontinuous maturation, retention of 13 and then 16 negative. This is kind of not following this pattern. This is kind of abnormal. So when you start comparing your things, so basically most of the labs, they have a normal plot as to how a normal should look like. They have developed their own plots and everything. So when you don't know, or when you don't remember what a 13 should do or what a 16 should do, you just compare, go back and compare your normal with abnormal, and you will know that this is abnormal. Hemodiluted marrow. So hemodiluted marrow, it will be more or mostly mature myelomonocytes that will be there. So basically the 16 spectrum that should be there will be lost. 11B, that is more of mature as well. So basically the mature myelomonocytes that will be there in case of hemodilution, right? And this is a normal, not hemodiluted. So basically there is a spectrum for 16, there is a spectrum for 11B, which is kind of, when it is hemodiluted, it is more of the mature spectrum, so it is lost. So they are showing that a V-shaped pattern that we have been learning yesterday as well. V-shaped pattern of 13 versus 38, and the 13 dip that I have been talking about since a lot of time, since yesterday. So that kind of pattern is normal. But however, if it loses that kind of pattern, that I mean that tick mark sign or something, if you is kind of having abnormal blob that is having retention of 13, so that's kind of an abnormal sign. You don't have that maturation pattern. So again, the same thing they are showing over here. The normal granulocytes without retention of 64. So normal granulocytes, as you see over here, the monocytes will be 64 bright, the granulocytes will be 64 dim. When it starts increasing the 64, that's abnormal. So again, all of this you might not even need in your practice if you're practicing in a small place where you're not even commenting about MDS. You might not need all of that. But when you are commenting on MDS, abnormal blast, abnormal myelomonocytes, and when you are doing that kind of thing, or else even when you're doing MRD, all of this plays importance. So any questions so far on the myeloid gating? Did it help? Did it clear something in your mind better than what you have been learning in flow cytometry so far?
Yeah.
In your institutions?
For sure.
Okay, good.
Definitely.
Good. So let's take a small break because I know that it is too much to take. Though I tried to simplify it as much as I could, but let's take a small break since it is today's more of like Saturday. We should utilize our Saturday and maybe feed your kids and try to come back in 10 minutes. So right now it is 10:54. We'll resume in 12:05. We'll try to utilize our Saturday and we'll try to see if we can go a little bit dive into normal B cell gating and normal T cell gating, just so that the B and T cell will not be as hard. So we'll just finish the B cell and D cell gating and we'll call it a day. Okay?
Okay.
Yeah, let's take 10 minutes break. We need some fresh time.
Hey. Hello. So why don't rush because of me? I don't want you to just. I'm doing the 3 days because I only have a week, and I'm also doing Vancouver, right? So that's why I was. That's why I'm okay with 2 if 3 days.
Yeah, no, actually, it doesn't cost you anything more. Like you're doing all of that
in like $50. Yeah, $50 or more. So yeah, so for me it's good, Dave. Like நீங்க வந்து bev
I'm back, guys. Let me know when we can start.
I'm back as well.
Okay. Are you guys back? You can just write back in the chat and I'll know.
Yeah, I think
Yes, we are.
Okay, cool. Okay. All right, so let's start again. I hope you had a nice break. A little refreshing. Okay, cool. All right, so the B cell plots and everything. So reminding ourselves of what we read in B cells yesterday. Let's see. Data materials. Where is that thingy? So we were reading this about the B cells, right? So we read 34 negative in case of pre and immature B cells, TDT negative in case of immature B cells. They will be more in the early on forms. 10 LMO2 is more of a follicular or germinal center marker, and it can, however, be present in the early forms as well. 19 will be negative, like get dimmer in case of plasma cells, but it is still there. In the normal plasma cells, it will lose 19 altogether. PAX5, PAX5 is more of like general B cell marker. CD79A is also B cell marker, but it is also present in the plasma cells. CD20 is more of mature. It will not be present in the early mature stages. It will start appearing dim in case of more immature, like later on immature stages. It will not be present in the plasma cells. And CD38 is present in the BLLs, and it's kind of there in the immature marker as well. We know that CD38 is brighter in case of plasma cells as too. CD38 will also be present in the normal germinal centers. BCL6 and GAL are also germinal center markers. They are more specific of the germinal center markers. MUM1 is more of plasma cell marker. It comes in brighter in the plasma cells. BLIMP1, CD138 are more specific plasma cell markers. So we reminding ourselves what we read yesterday. And then we also read the Brentwood article that we did the normal B cell maturation. We had the same thing over here, what I emphasized in that thing. 38 being more of plasma cells, 80 and 34 not present in the immature mids, and 20 coming late. Yeah, this IgD, IgM, kappa lambda. So kappa lambda will be more of polyclonal in case of normal B cells. IgD, IgM is more present towards the naive B cells, and that I showed in here as well, that these naive B cells, they will start expressing IgM and IgD. So for example, the membrane IgM starts coming in immature B cell, and the naive B cells, they start having IgM and IgD. So same thing he is showing over here, that the IgM, it starts coming in the naive B cells. That's what it is showing again. So IgD as well, it's coming in the naive B cells. So let's see what our flow SOP has to say. All right, so B cells, they are saying that the gating of the B cells, as we all know, CD19 will be the like lineage defining B cell marker. So they're gating based on B cell positive cells. Abnormal B cells can be CD19 negative, but if they are either CD20 or 22 positive, then throw away B cell gate on CD20. So basically, remember that CD19 is not the only one. And if you know the criteria for MPAL, for example, for the MPAL, they have given this criteria that CD19, that is the alone criteria. But if CD19 is negative, they have given other markers, CD20, 79A, and so forth markers, that if positive, then it is also B cell lineage, right? So if it is CD19 negative population, then you go ahead and do the gating on CD20, 22, 79A, and so forth. So can anyone tell me what this green population is?
T cells?
Huh? T cells, yeah. So, just a second. So yeah, so these are the B cells over here. These are the mature B cells, CD5 negative, CD19 positive, and these are the T cells, CD5 positive, CD19 negative. There's a junk that comes in between these two, and you have to exclude the junk or debris that comes in between. However, I mean, it's different in different labs, and not every lab might have. So again, the B cells and T cells that they have shown, and the junk that comes over here. Using even the internet. Where did it go? Okay. Now coming to the plasma cells, as we have been saying, CD38 bright is the plasma cells. They will be dim in CD45. Those is your plasma cell clade. Normal B cells, they should be both kappa lambda, or they can be light chain negative B cells as well. So normal B cells, you can see there are mixture polyclonal kappa and lambda. When it starts being monoclonal, you think that that's an abnormal population. So the maturation of B cells, and you see that as I was showing this figure, let's see again. As I was showing this figure, that the immature B cells will have CD10, right? And then as they start maturing, they will lose their CD10. So similarly, what they are showing over here is the immature B cells, the early B cells, they have CD10. And then as they mature, they start losing CD10. So basically intermediate B cells and then mature B cells will not have CD10 unless it is a granulocytic, a germinal center B cell. Let's skip this for a second and go into the germinal center B cells. So as I was saying, the germinal center B cells will also have CD10. And the CD10 bright, CD38 bright population that will be there is the germinal center. And the germinal center will have a brighter CD20. For example, if you compare from this spectrum, the germinal center will have a brighter CD20 as compared to the other B cells. And so again, they are showing the same thing over here, that the germinal center is brighter CD20 and CD38 than the normal population. This abnormal BALL, what they are showing is, so there is a blob, as I was saying, and this blob is negative for CD20. So first thing first, we saw over here that the CD20 is more mature marker. It comes later on, right? So it will be negative for CD20. It's abnormal immature blasts, and the CD10 will be positive. And CD38 will be positive in some of the immature. So again, we were coming to this. We can see that CD38 can be present in some of the immature blasts, B cell blasts as well. So you can see that some of the immature B cell blasts will have CD38 that is present. 19 is present, though it is a little dimmer than the normal B cell blasts. So this is your normal not blasts, this is your normal B cells. And you can see that this is your normal B cells. It's that. Okay, my 7-year-old kid, he likes immunology, and so as soon as he heard about B cells, he got excited. Okay, anyways, sorry about that. So, okay. He's kind of having his head in front of my laptop. Sorry about that, guys. Okay, so that please, bhag jaye yahan se. So I was saying that this uh, normal B cells. So you can see the CD19 is a little dimmer than the normal B cells, and of course CD20, which is dimmer than the normal B cells. That's that.
Akansha, can you just go back 1 second?
Yeah, go ahead.
Yeah. So 5 here is it like where the -5s are?
The -5 would be like the T cells 5 would be over here, right?
Here.
They're having a little bit of 5 here.
Okay. So that's like abnormal. I haven't seen a 5 positive or a dim 5 positive blast. But anyways, let's just ignore that 5 versus 20 plot. And I have a question for our audience. Assuming if the patient is a known case of a follicular lymphoma or whatever, and they have got rituximab, which is an anti-CD20 monoclonal antibody therapy, the plot, how would you differentiate that?
I'm not able to hear very well. Your voice is very dim for me. I don't know why.
Oh.
Yeah, please, can you repeat the question?
Okay. Let's just ignore the CD5 versus CD20 plot for a minute, and just with the rest of the plots, if assuming the patient has a history of follicular lymphoma and is undergoing treatment with rituximab or an anti-CD20 therapy, how would you differentiate that from a lymphoblast? I mean, this question is for the audience, just to interact. Does anybody know? Okay, so you will use the kappa lambda to differentiate a B lymphoblast from a CD20 therapy follicular lymphoma, because your mature lymphomas will have surface kappa lambda expression, whereas your immature BALL cells will not have surface kappa lambda. Just wanted to bring that up.
That's a very nice point. Okay, good. Very good.
And follicular lymphoma cells will also have like 19 and 79A, right? But the ALL cells will not have those.
19 will be positive on follicular lymphoma, and 79A we won't. It's a cytoplasmic marker again. Mostly we won't use it for our regular panels. You can if you want, but 19 will be positive in blasts. 19 is consistently expressed from blast stage to mature B cell stage and plasma cell stage. It's always there.
Okay, got it. Thank you.
Yeah. And we will come to that. There will be a situation when 19 will not be helpful. We will discuss that when we discuss BALL. But at least for mature B cell lymphomas, right now they are only using CD20 antibody therapy. And that is something we always have to check the patient chart for and keep in mind, because sometimes in high grade lymphomas that can be CD10 positive, they may not express surface light chain, so that it kind of gets tricky there.
Okay, that's a good point. Thank you.
So as Raji was saying that 19, they can be expressed in the B blasts of B cell origin, as you can see over here. And these are the normal mature B cells that are bright for CD19. So it will be having some dim CD19 expression, but the brighter will be on the normal B cells. The blasts will have no light chain expression, as Raji was saying. The normal B cells will have kappa lambda, but the blasts will have no light chain expression, the BLL blasts. The blasts, as I was showing over here, so this is very helpful. The blasts have CD38, right? So the blasts will have CD38 expression, along with the normal B cells will not have CD38 expression. So that's what it is showing here. The normal B cells not having the CD38 expression.
Do you usually do TDT marker in BLL? I think TDT would also help. I know it
Yeah,
has some spectrum too.
right. It does help when you do it. But in our lab in MSK, we didn't used to routinely do CDT because the other markers were enough to call it a BALL. It is a special intracytoplasmic tube.
Yeah,
And
I know.
in
Yeah. In my
Kaluga,
both practices, they were doing it. So I was just
yeah,
thinking that's how I used to do it. So I mean,
right,
just that.
right.
Oh, it's okay. Yeah.
No, yeah, and in fact, where I am practicing right now, they also do TDT as a routine. Like they do, if they are doing anything for acute leukemias, they will do an acute panel. They will do an intracytoplasmic MPO and intracytoplasmic TDT. These will be
Yeah, that's
all
what
the
I'm
panels.
used to do. Yeah.
Yes, these will be all the panels that they will add. So that's a routine practice. In so every, as I said, every lab is different. And someone had this question, a subset of T cells can have CD10 expressions. So that's something that we have to remember. Okay, that's about B cell maturation, B cell gating and plot. Any questions so far or anything that you want to say?
So about the T cell subsets showing CD10 expression,
Mhm.
I mean, those are the follicular helper T cells which are there inside the germinal centers. If there are reactive germinal center hyperplasia, sometimes you can see that, but they should not be monoclonal. I mean, you will see a distinct subset of T cells, aberrant T cells expressing CD10 in angioimmunoblastic T cell lymphoma inflow. If you see T cells having CD10, always see if they are losing any regular T cell markers. Make sure they are not aberrant.
Very good point. Okay. Any other questions? Any other comments that you guys have? Anything else that you can teach? Okay. So let me dive into T here. T cell journey, B cell journey of T cells. Okay. Okay, so this is something that we didn't. Oh, that's B again. Just give me a second. I'll pull out the T here. One zero nine one one one. Okay, so this is the T, and we didn't. I think we didn't do this one yesterday. So let's quickly go to the T one. So basically, the central lymphoid tissue that consists of thymus and the peripheral lymphoid tissue that consists of lymph node. So central lymphoid tissue will have pro-T cell, cortical thymocyte, the common thymocyte, and then medullary thymocytes. So pro-T cell, so again, CD34 will be present in the bone marrow when it is in the stage of pro-T cell. Then coming to when it is cortical or medullary thymocyte, it will first have double positive CD4, CD8 T cells and alpha beta. And when it goes to medullary thymocytes, it will start having either differentiation into either CD4 or CD8 T cells. And over here, the TDT will be present in up till cortical thymocyte or a little bit on the common thymocyte, but the TDT is not present on the more medullary forms over here. Again, CD10 is similarly as so CD10, if you see over here, it is present in the T follicular helper cells on the right hand side in the lymph node. but it is also present in the early forms. CD7 is a more common lineage marker, and it will be present all throughout the T cells. CD2, however, comes a little later, and CD2, CD5 will be coming after the pro-T cell stage. Cytoplasmic CD3 is more of immature marker, and it will be like dimmer or negative in case of the other T cells. And as I said, that the early common thymocyte will be CD4, CD8 positive, double positive, alpha beta. And then eventually all these cells will become either lineage specific, like CD4 positive or CD8 positive T cells. CD1A is another marker. CD1A is important in ETP ALLs and early T cell precursor ALLs. And this CD1A becomes positive in the cortical thymocyte and common thymocyte. We know that T regulatory markers and T follicular helper markers. These T follicular helper markers, BCL6, ICOS, PD1, CXCL13, when do we read about these T follicular helper markers? Does anyone remember? So that we read in angioimmunoblastic lymphoma, right? So angioimmunoblastic lymphoma, we have these T follicular helper markers that are present in angioimmunoblastic lymphoma. Similarly, the T regulatory markers, CD25, FOXP3. Do you remember what tumor do we, or what lymphoma do we read CD25 in?
25, I think, is CLL that sometimes have it, and FOXP3 is follicular, right? That's, I don't know. I'm missing. Sorry. No, I'm wrong, maybe.
Are we asking about the B?
So I'm talking about the T here. So T, the ATLL.
Oh, yeah.
Go ahead. Someone was saying something?
No, I was just asking. Are we asking about CD25 in B lymphomas?
No, T. Yeah, that's what I was saying. So T, we see in ATLL these T regulatory cells. So that's something that we can remember. So after reading this, we can read the Brentwood T. Normal T cell maturation. So this will be similar to what we have been reading, but let's see, prothymocyte, immature thymocyte, common thymocyte, mature T cell. CD34, early negative, even like dim. TDT will be the one. So that's why we were talking about the cytoplasmic TDT tubes and cytoplasmic MPO tubes. CD7, like overall marker, CD2 will come a little later than will not be like dim or negative in case of the early forms. CD5 will be dim or negative in the early forms, will become higher in case of mature T cells as they mature. Cytoplasmic CD3 dim, and then it comes in the other immature forms, and then cytoplasmic CD3 it vanishes or decreases. As we were talking about initially, they are double positive CD4, CD8, and then they are lineage specific. CD3 is more of surface. Will be present in the later on stages, and as the T cell receptors. So let's see what they are showing here. So as the T cell progresses, let's see. So they kind of start gaining CD3, as you can see over here, and oh, this is TLL. That's not this over here. So they are comparing the TLL actually. Let's not go dive into that. So okay. So this is the normal T cell gating, and for the normal T cells, you know that the surface CD3 is, as I said, the more mature T cell marker, right? So the surface CD3 is the one where we are going to gate, and the normal mature T cell, as I was saying, the double positive T cells will be the more immature ones, right? So the normal mature T cells will be CD4 or CD8. It will have more of either CD4 or CD8. So natural killer cells will be gated on CD7 positive and surface CD3 negative expression. So those will be the natural killer cells, CD7 positive, surface CD3 negative expression. And there are other ways that you can wait on the natural killer cells as well. This we will, Cesare and the others will read more in detail when we are doing the particular cases. We can come back here and read more of this. So that concludes our B, T, and myeloid. I was hoping to read more of maybe the Brentwood early on chapters. Let's see, I don't have it downloaded. Actually, I might have it downloaded. Let's see. So I was hoping that we would do like these early on chapters that have that have this introduction chapters, introduction to B cell and T cell. They have shown nicely before they dive into cases as well. So I don't know if it is in our scope for today, but let's see. But the introduction part and everything, they have gone through everything that we went through, just in not as detail as we went through, because the ones that we went through were much in detail. But everything you can see that they are explaining everything that we have already gone through. The myelomonocytic gate, we have gone through in much detail than this. T cell development and everything. So then they are going into T cell neoplasms and everything. So let's skip these chapters because we don't have enough time. And plus it is more and less the same thing. The Brentwood book is the same as Wood list. So we kind of covered all of that. So starting, let's see, anything else was in our agenda. So we did the myeloid T cell gating, Brentwood article, we did that. Gating analysis procedure. I also was thinking that maybe I can show you the normal peripheral blood flow that we have in Kaluza, because what we have been reading right now was Wood list. Maybe the next time I can show you these normal plots. In fact, I can show you in Kaluza itself as to how it looks like. Like this is our Kaluza, and I think I de-identified these things. Let me quickly check. Yeah, I identified these things. So, I mean, I want to go through a little bit how it looks like in Kaluza. For example, this is your normal plot. So as I was saying, that CD45 versus site scatter. So this is what most of the institutions they do. They have CD45 on the x-axis and site scatter on the y-axis, and that's how it looks like, and that's how we have been trained that the CD45 bright, sorry, the site scatter bright is the granulocytes. The highest CD45 is the lymphocytes. The monocytes come in between, and the blasts are dim CD45 and dim site scatter. So that's that. So over here, remember that this blue population is our monocyte population. Let's go back. The red population is the lymphoid population. So this will help you going further. So blue is monocytes, red is lymphoid, black is blasts, and green is granulocytes. So again, the HLA-DR will be negative in the lymphocytes. It will be there in the monocytes. It will be dim in case of granulocytes. We have been studying all of that in a different fashion, but this is how it looks like in Kaluza. The monocytes will have CD64 brighter than the granulocytes. We have been reading that, and it will have CD33 brighter than the granulocytes. We have been reading that. The T cells will not have 6433, as we already know. So, I mean, this is much more simplified form of what I have shown you. I showed you the father of everything. Once you know that, you will be, this will feel like a child's play to you. So you can see that 14 is positive in the monocytes, and this is of course the peripheral blood. So basically you are having a mature monocytes, not much of the spectrum here. And so this is where your erythroids will lie, if at all present, but in the normal peripheral blood, you don't see erythroid, so you don't have much of here. CD71 I was talking about. CD11B, the monocytes will be brighter. And again, the CD11B, the granulocytes will also be there. So that's that. So you don't see that maturation pattern in case of, as I was talking about in the bone marrows so far, that you see this kind of variable pattern in CD13, CD33. What's the reason? Because we don't see those immature cells in the peripheral blood. As I said, this is a peripheral blood, normal peripheral blood plot. So you don't see that maturation. You really have, what you have is a normal mature granulocytes that are having bright CD13 and 33. And the monocytes will have brighter CD33 as compared to the granulocytes. So that's that.
Hey, Kanksha, can you move 2-3 plots above, back? This one, stop at this one. Maybe this one too. The second plot, the granulocytes, they, like instead of like, if you see in side scatter in 33, the granulocytes, they are very concise plot, but they look kind of a spread. The green plot I'm talking about in 64 and side scatter, they look kind of a spread out, and even in the plot below, which are like in my screen, they're half.
That's not an abnormal. Yeah, go ahead.
Yeah, so these are not abnormal. I mean, how do you decide on? I mean, these are the things that, like, you know, I worry on. Like, is it going towards some abnormalities? There's some immaturation coming up, and then one plot is normal, another plot is kind of like spreading.
When you have hypergranular neutrophils, you will have more of the neutrophils that are having low side scatter because they don't have granules. But this kind of maturation of the neutrophils, some are having this kind of variable expression of side scatter in neutrophils or granulocytes is a normal expression pattern that you see, and you always remember that this is how normal plot looks like. It will have a normal. If there are hypogranular neutrophils, it will fall somewhere here that will be having very low side scatter or negative. Maybe.
Okay. Like here in this plot, like they're kind of making two columns, you know, like the
Yeah, that's like when you see CD13, if you remember, there is one stage in the maturation of granulocytes.
Oh, okay, now I get it. Yeah. Oh,
So that's
okay.
like promyelocytes, and rest of them are metamyelocytes and neutrophils. That's what it is.
Okay.
And
Okay.
you won't see side scatter versus CD13 or anything in if you're like signing out regularly.
Mm-hmm.
This is like Akanksha said, these are much in detail because this is probably their SOP, so they have everything in there. But you won't see side scatter versus all these, so don't worry about it.
Okay, good. Thank you.
Yeah, so then they are diving into they gated the lymphocytes, and they are just diving into the lymphocytes that they are 1333 negative, CD117 negative, 14 negative, HLA-DR negative, and 64 negative, 11B negative, or maybe a little bit of spectrum. There is a little bit of 11B in the lymphocytes as well. So that's your normal lymphocyte. Let's see the B. So one thing to remember in the B over here, we don't have that. I wanted to show that. It's somewhat similar. Let's not. Cytoplasmic MPO. This is what I was talking about, the cytoplasmic MPO. So normally in the peripheral blood, you will not have the MPO that is positive. And like they will be, actually, they will be present in the normal, that's right. They will be present in the normal myeloid series. So as we know, the MPO is present in the normal myeloid series. So when you have to differentiate the blasts, whether they are MPO positive and normal, if they are myeloid lineage, you go for MPO panel. And this is again the lymphocytes, so that's not relevant. So if you remember, the normal peripheral blood will not have TDT positive cells. They are more of immature markers. So it should not have TDT positive cells. And again, these are the B cells, your B cells, 19 positive, and more of kappa lambda monoclonal. I wish that they have shown there, but monoclonal kappa lambda and CD79A on the B cells. These are your T cells, the pink population. So that's your T cell with cytoplasmic CD3. So when this is all the same, CD79A. So 79A, 19, 22 cytoplasmic CD22 positive, all of these. So these are like your normal plots that you might come in most of the laboratories, and this will.
Sorry for interrupting. I think that CD19 positive one, are they the normal B cells or they are hematic ones? They are like dimmer on CD19. Like I think the normal B1 would be more stronger than on CD19 and other plots.
Remember one thing, that hematocones are not seen in a normal peripheral blood.
Oh, okay. Yeah, that's the thing. Yep.
So these are normal mature B cells.
Okay, got it. Good. Thank you.
Yeah, so this will be an easier, like this is how the most of the laboratories will look like. The wood list is the BAP, I said, like the father of everything. It has much more complicated, and once you are done with that complicated thing, these will start looking like child's play to you. So these are those same things, like the normal T cells will have CD4, CD8. There will be some double negative as well. So let's start. They will be having CD5, CD7, CD2. So all of these are T cell markers, and that's how a normal T cell will look like. The important thing is that you should have more CD4 than CD8. The CD4 CD8 ratio should be around 2 to 3, and you should have more CD4 than CD8. When you start having more CD8, then you start thinking of the other kind of LPA, the LGL populations, and so forth. Okay, so that's about it. Let's call it a day. We have been reading from like 1 hour before and like quarter hour right now. So we were able to finish our agenda today, and we finished everything that I wanted to show. There was this normal analysis, but let's not dive into that maybe. From tomorrow onwards, we are going to, so let's see the schedule. So that's the year schedule. Tomorrow onwards, we are going to 8-11, right? We are going to dive into the cases, and Rajeshri has pulled out some cases, and she'll be pulling out most of the cases for us actually. And then she'll be going through the cases before we go into Brentwood book, and we'll go into the Brentwood book and read about those cases as well. So if you want, you can just go through basic stuff on Brentwood if you want before we start the tomorrow's session.
Okay, and I'll be placing the cases in the drive, most likely in another half an hour or an hour, or at the latest by this afternoon. So it would be great if you guys could look at the cases before you come, and then we can discuss the cases. So this way, you will know if you have any questions, and then we can address them. But we are starting light. These are simple cases, and then we'll go from there.
Right. I mean, the yesterday's session was the heaviest session. I think the myeloid and everything, monocyte maturation and everything. But today it became a little more clearer, I think. And now we are diving into the B cell, which are the easiest of the bunch for flow cytometry. Then we'll be diving towards T cell, which are moderate in hardness, like in complexity, and then the myeloid is the myeloid is myeloid. So after that, we'll be having the unknown cases.
Yeah. So every day before discussion, the day before we'll put the cases in the evening. We'll put it in the drive and try to take a look and before you come to the session the next day. And then first in the session we'll discuss the cases that are in the drive, and then Akansha will go over the Brentwood chapters.
Yeah. All right. Let me know if this was a useful session for you all. And if you have any feedback, like Shweta sometimes have nice feedbacks, and that helps us. So if you have any feedback, that would be appreciated too. Okay.
Thank you. Thank you.
Thank you. Thank you for making it so simple. It's so complicated the way you guys like summarized everything. It really helped. Thank you.
Thank you very much. Thank you.
Thank you.